Well, good afternoon. My name is Felicia Taylor, and I'm the CEO for the New Jersey chapter of the American Academy of Pediatrics. Thank you for joining us for this presentation on Project Firstline, Part 1, Basis of Infection Control for COVID-19. This is the first of 2 Project Firstline webinars. Now I'll talk about a few housekeeping items. Today's webinar will last 1 hour. All attendees will be muted throughout the webinar in order to minimize any disruptions to the presenter. If you do have questions related to today's presentation, please submit them through the Q&A box on the webinar control panel. Any questions remaining unanswered at the end of the webinar will be compiled and the answers provided to participants a few days following the webinar. CNE, CME, and MOC Part 2 credits are being awarded for your participation in today's webinar. You will receive an email concluding this session. Again, the webinar is being recorded, will be made available on the NJAAP website, and the information to access the webinar will be sent to you in an email after completion of the webinar with resources and a survey link. Once your quiz is submitted, your credits will be issued and you can expect your certificate emailed to you within 30 days. Now, on to our speaker for today. It is my distinct pleasure to introduce our presenter for today's webinar. Dr. Renuka Verma completed her residency at Monmouth Medical Center and fellowship training in pediatric infectious disease at the State University of New York, Stony Brook. She serves as Director of Pediatric Infectious Disease, as well as the Program Director of the Residency Program at Monmouth Medical Center. Now, without further delay, I will turn the presentation over to Dr. Verma. Dr. Verma, the floor is yours.
Thank you, Felicia. Good afternoon, everyone. COVID-19, SARS-CoV-2, MIS-C, are some of the terms that we have learned in the last 1 year. What makes COVID-19 infection control a challenge and a concern is that it is a new virus. We are still learning about it. The treatment and vaccines are just about coming for the masses and general population. And even more challenging is that we all are susceptible to get infected with this virus. We all can get infected by doing something that is normal part of our daily lives. And on top of that, we have no idea as of yet why one gets more severe illness than the other, and how someone who has no symptoms can still transmit the infection to others. And therefore, the key is in the approach that we take to prevent the infection. Use of proper personal protective equipment, the reasoning behind that, knowing about the source control, also triage and screening of the patients, as well as an environment and the hand hygiene. To begin with, I have no disclosures, but the disclaimer is that the things that we are going to discuss today, they may change as the time comes. Our objectives for today are understand the roots of general infection transmission, discuss infection prevention and control practices recommended during COVID-19 pandemic, learn new AAP recommendations for sports clearance, and also discuss some COVID-19 transmission scenarios if the time permits. So let's start with the basics. Anytime we are learning about the epidemics and knowing about the pathogen, there are 3 elements to learn or 3 elements to study. The source of infection, which could be any pathogen, bacteria, or virus, which are found in many places, including in many healthcare settings. The second element is people, patients, healthcare workers, and visitors. And of course, the environment, which includes dry surfaces in the patient care area, wet surfaces, moist environments and biofilms, indwelling medical devices, dust or decaying debris. So the transmission of infection is a way where the pathogen is moving from source of infection to the susceptible person. And pathogens depend on people, the environment, and also the medical equipment to move in the healthcare setting. The pathogens can travel in a healthcare setting through 4 different ways: by contact, touching, sprays and splashes, inhalation, sharp injuries, which could lead to bloodborne pathogen infection. A little more about the 4 different infection transmission ways. The contact transmission occurs when a healthcare person is touching or examining a patient and does not follow the proper hand hygiene practice. They can transmit the infection to the other susceptible person. The common examples are MRSA or methicillin-resistant Staph aureus, vancomycin-resistant Enterococcus, and Clostridium difficile. Sprays and splashes occur because of the mucus secretions from a person who is either coughing, laughing, or talking, and that droplets can spread or travel in the air, can remain suspended in the air, as well as go to the surfaces, and by touching and inhaling, you can transmit the infection. The common examples are pertussis, meningitis, and RSV infection. Inhalation is the same way. However, in the inhalation case, the droplets are very small size and the infectious material is very contagious and it can remain suspended in the air for a prolonged period and therefore is able to transmit the infection. The common examples are TB, measles, and varicella. And of course, sharp injuries can lead to bloodborne pathogens such as HIV, hepatitis B, and hepatitis C. So let's come to COVID-19. Infection transmission in COVID-19. The COVID-19 spreads very easily from person to person, including from people who don't even seem to have symptoms. And like flu, COVID spreads in situations where people are very close together to each other through respiratory droplets, which are produced from an infected person while coughing, sneezing, talking, and laughing. There is no evidence of transmission through the skin for COVID-19. In general, the closer a person interacts with the other, the longer the interaction is, the risk is higher for COVID transmission. Being with others in an enclosed space which has poor ventilation, the transmission risk is very high, especially in situations where people are really close together, shouting, singing, laughing, and doing things which are able to produce droplets. SARS-CoV-2 can also be aerosolized in situations such as aerosol generating procedures, such as intubation or nebulized treatment. And those are certainly high risk for infection transmission. So how do we prevent infection? There are 4 different ways the infections are prevented in hospital or healthcare setting. The one that is most important is the standard precautions. Standard precautions are used for all patient care, and it is based on the risk assessment with the use of common sense practices, personal protective equipment, and use that will protect healthcare workers from infection as well as prevent spread of infection from one patient to the other. What that includes: good hand hygiene, proper use of personal protective equipment, following the respiratory hygiene and cough etiquette, ensuring proper patient placement, proper handling and cleaning and disinfecting of the patient care equipment, also handling and the textile and laundry carefully, following safe injection practices and proper handling of needles and sharps, and wearing surgical masks for the procedures. The bottom line is that standard precautions should be used by healthcare personnel caring for patients, regardless of patient's diagnosis, whether or not the patient is known to have communicable disease, or in other words, standard precaution must be used for all patients all the time. So what involves in the standard precaution is generally hand hygiene, personal protective equipment, which includes gloves, mask and eye protection, and gowns when soiling of the cloth may occur. And this is the one that we are using for COVID-19. And in this, the mask, gowns, gloves, face shields, they are all important in preventing the infection as well as the gloves. So the personal protective equipment that is needed for COVID-19, the recommendation is the barrier should be used for eyes, nose, and mouth to protect from protect the mucous membrane and protect from the mucus discharge. Filtering respirators to prevent inhalation, gowns and gloves to make it easy to remove infectious secretions that you might have touched. Remember, your PPE only works if you use it correctly every time. The N95 mask that does not have a good seal on your face or gloves that are not removed carefully is not preventing you from infection. When caring for a patient with SARS-CoV-2 infection, remember to adhere to standard as well as transmission-based precautions. And I will touch on the transmission-based precautions in a minute. Ensure adequate training and opportunity for practicing donning and doffing of PPE is very, very important. Step-by-step donning as well as doffing is very important for safety of the patient as well as safety of the healthcare worker. We should have signage outlining or both this procedure of donning as well as doffing, or have videos that would walk through every healthcare person to learn about the actual procedure. Can we reuse the personal protective equipment, especially in situation with COVID-19? When caring for asymptomatic patients with unknown status, mask, eye protection or eye shields, and gowns may be used all day if not soiled or contaminated. If some or all of these items are reusable, then they can be sanitized and used for the next day. However, gloves should always be changed between the patients, and hand hygiene must be performed with the glove changes. When caring for a patient with COVID-19 compatible disease, gloves, gowns should be removed and disposed of between the patients. Eye protections such as goggles and face shields should be sanitized between the patients, and masks should be changed between the patients unless covered by a second, either face shield or the second mask. So in general, a lot of people use a surgical mask on top of the N95 mask, so you can get rid of the surgical mask and your N95 mask will remain in place. When you're doing some kind of aerosol generating procedure, then of course the full PPE must be used, and also it should be used in a proper fashion. The PPE that is specific to COVID-19 patients, as I mentioned earlier, transmission-based precautions are used in addition to the standard precaution for patients with known or suspected infection. So let's talk about the droplet precaution or droplet infection. Droplet infection or droplet precautions are important in COVID-19 because the source of infection is coming from the mucous membrane. And the first thing first is the source control. We have to make sure that the mask is placed on the patient so we can control the mucus secretion and its spread. Ensure appropriate patient placement. In the hospital setting, these patients should be put in a single room. In an ambulatory setting, the patient who has COVID-compatible disease should be put in the exam room as soon as possible and should instruct to follow the respiratory hygiene and cough etiquette recommendation. By knowing their illness or symptoms, the healthcare provider can also be ready with their PPE to be able to take care of those patients. Use the PPE very appropriately, don the mask upon entry into the patient room and or patient space. Make sure that you're using hand hygiene as appropriately as possible. Movement of patients should also be limited as much as possible. In hospital setting, for any reason, if the patient has to be moved, we must put the mask on the patient and also instruct them to use respiratory hygiene. If a patient cannot use the mask because of the younger age or because of respiratory difficulty, the tissue could be placed on the face, covering nose and mouth. The mask is a very good equipment or tool for the universal source control. However, the cloth face coverings are not considered personal protective equipment in the hospital setting. They are good for source control. Healthcare providers should wear appropriate PPE, not just the cloth face covering. Cloth face covering should not be used instead of PPE if more than source control is required, which is generally the situation in hospital settings. For visitors and patients, a cloth face covering is appropriate, and cloth face covering should not be placed on children who are under 2 years of age or anyone who has trouble breathing or is unconscious, incapacitated, or otherwise unable to remove the mask without assistance. And again, for those patients, the tissue over face or rather nose and mouth is appropriate. Just the picture depiction of the universal source control. If infected person is not covering the face, he's definitely putting a risk for everyone else. If you put a mask on the infected person, you are doing a source control. And if you are wearing the mask, and then you are doing the protection for yourself. The ideal thing is the both infected and uninfected should have the face covering or face mask. The next piece in the droplet as well as in the contact precaution is the hand hygiene. When should we wash hands? Whenever they are dirty, visibly or contaminated. Before having a contact with the patient, before putting on gloves, before inserting any invasive device, or before manipulating any invasive device or any contact in the patient room, as well as after contact with the patient, after contact with the body fluid or excretions, after contacting non-infected skin, wound dressing, or contaminated items, or having contact with inanimate objects near the patient, such as bed rail or table, or even doorknobs, and also after removing the gloves. So why are alcohol-based hand rubs are so great? Alcohol-based hand rubs kill more effectively and more quickly than hand washing with soap and water. They are less damaging to skin than soap and water, resulting in less dryness and irritation. They require less time than hand washing with soap and water, and the bottles and dispensers can be placed at the point of care, so they are more accessible. So at this time period, I think alcohol-based hand rubs are really good and effective. How do I practice hand hygiene correctly? So for hand rubs, which are alcohol-based, take a little bit of foam or gel, put on the palm, rub the hands together, covering all surfaces, including fingertips and fingernails, until it is dry. Generally, it takes about 15 to 20 seconds. For hand washing, wet your hands, apply the soap, rub together for again 15 to 20 seconds, covering all surface areas, including the fingertips, fingernails, and in between the fingers. Rinse under the running water and use the disposable towel to dry it, and then use the towel to turn off the faucet. The bottom line is the hand hygiene is important before and after each patient contact, even if you have used disposable gloves. And I want to emphasize the point here that don't think that the gloves are preventing infections if you are not doing the hand hygiene. So whether you're using gloves or not, hand hygiene or washing hands or using the alcohol-based the gel is always important. Recommended practices for the patient, those are exposed to the SARS-CoV-2 infection. In those patients, if the hospitalization is not necessary, then home care is the best. Patients should be isolated in a single room if needed hospitalization and should be cared for by a healthcare provider using all PPE that is recommended for suspected or confirmed SARS-CoV-2 infection. Patients should not be cohorted with the other SARS-CoV-2 infection unless they are confirmed to have SARS-CoV-2 infections, meaning two patients with the two different diagnoses should not be placed in the same room. Recommended practices for patients with suspected or confirmed SARS-CoV-2 infection. Again, if the hospitalization is not medically necessary, the home care is preferable. If the patient need to come in the hospital, they should be in a single room with the door closed, and preferably the room should have negative air pressure. If possible, the facilities actually should consider using a single unit or entire unit for all patients with SARS-CoV-2 infections with a dedicated healthcare provider staff. Also limit the transport and movement of these patients across the hospital. Communicate the information about the patient's status to other departments if the transport or movement is necessary. And also, when the patient has to be moved, face mask or cloth mask must be used by the patient. Personal protective equipment for when you are caring for the SARS-CoV-2 confirmed patient, healthcare provider must use the National Institute of Occupational Safety and Health approved N95 or any higher level respirator, gowns, gloves, and eye protection. You must perform hand hygiene before and after each patient contact. And the training for using the PPE properly, putting it on, taking it off is a very essential piece in controlling the infection transmission. If the aerosol generating procedure is to be done for a patient who has SARS-CoV-2, healthcare provider in the room must wear N95 or higher level respirator, eye protection, gloves, and gown. Limit the number of healthcare providers that are present in the room. Only essential people should be there. Visitors should not be allowed, and procedures should take place in a negative pressure room. And also, right after the procedure, all the equipment and the area must be cleaned properly. Visitors in the areas where the confirmed SARS-CoV-2 patients are being cared for, limit the visitors to the facility to only those who are essential for patients' physical and emotional well-being, such as in pediatric wards, one parent per child. Encourage use of alternative mechanisms such as the video calls or FaceTime. And if the visitation to the patient with SARS-CoV-2 occurs, it should be scheduled and controlled. And of course, the visitors should also wear masks and follow the respiratory hygiene. Optimize the indoor air quality, and this is the message for all the facilities. They can optimize the air handling by checking the system for appropriate direction, filtration, exchange rate, and proper installation, as well as maintenance. If those systems are not in place, there are portable HEPA filters available to increase the air quality in the area, and that would be an appropriate option. Communication regarding the transmission-based precautions are very important for all healthcare providers. So for contact precautions, contact type of precautions, you need cleaning your hands before and after, putting the gloves before you enter the room, discard the gloves after you exit the room, put on gown and discard the gown after the exit, as well as clean. First of all, use the disposable equipment or reusable equipment should be clean. For droplet precautions, hand hygiene is important, as well as the face mask and face shield. For airborne precaution, everybody should do hand hygiene, proper N95 mask, and negative pressure room, and the door must be closed all the time. In case of COVID-19, as we have already discussed, that the healthcare provider must have N95 masks, face shields, gowns, and gloves. This should also be communicated with your patients and parents. So the message is that everyone should keep the distance, cover your cough, When in the public, wear a mask on your that covers your nose and mouth. Do not touch your eyes, nose, and mouth. If you do, wash your hands. Clean and disinfect the areas that are commonly used. If you're sick, stay home and wash your hands more regularly for at least 20 seconds. Also, keep the messages around and keep telling them that if you have symptoms like fever, cough, shortness of breath, fatigue, body aches, headache, loss of sense of the taste and smell, sore throat, congestion or runny nose, nausea and vomiting, and diarrhea, please call. Call ahead for the appointment so your visit could be arranged in an appropriate fashion, or patient could be sent to the emergency department depending on the illness. These messages should be there at the entering and exit areas of the building, as well as break rooms and lunch rooms, so everyone can be reminded of the requirement. The next is, when can we discontinue the transmission-based precaution for COVID-19 patients? Symptoms-based strategy for the discontinuation of the transmission-based precaution is practiced. Patients with mild to moderate disease who are not immune compromised, generally after 10 days of illness from the first symptoms, they can come out of isolation. Last 24 hours, they should not have any fever. Last 24 hours is those 10 days, and should not have used any fever reducing medication. And of course, the symptoms have improved. So 10 days, no medication in last 24 hours, no fever, no symptoms, they can be out of isolation. Patients with severe to critical illness or those who are immune compromised, they generally require anywhere between 10 to 20 days since the first symptoms appear. And the same way, no fever in last 24 hours, no fever reducing medication, and no symptoms. If any concern is still there, then they should consult their physician or infection control experts. Generally speaking, we do not use the test-based strategy because many patients can continue to shed virus for 12 weeks and longer. Just a quick word about the isolation versus quarantine. The isolation is for 10 days or a little longer, depending on the severity of the illness, when the person is sick, versus quarantine is when you're exposed and you have to stay in a quarantine for 14 days. And that's the difference between the isolation and quarantine. So what do we do in outpatient facilities and ambulatory care practices? Generally speaking, you know all your patients. So if you know any one of your patients who is at risk for severe disease with COVID-19 and is afraid to come to the office, please make sure that they are getting their sufficient medication refills, and also instruct them to call if they become ill so they can be cared for. Ask for symptomatic patients who require in-person care to call before, so the staff can be prepared for them and the patient can be put in the room as soon as possible. I know pediatricians don't do that, but just for the sake of completeness, do not penalize patients for canceling or missing appointments because they are ill. Place visual alerts and signs and posters in appropriate languages in the entrance area and other strategic places for hand hygiene, respiratory hygiene, face covering, and cough etiquette. So we continue to want to educate our populations. Set up waiting rooms to allow patients to be at least 6 feet apart, and reduce the crowding in waiting areas. And you can also stagger the appointments or ask them to stay in the car until their time or the room is ready. Another option is to set up some triage booths to screen patients, and generally in larger settings, it can be done, but in colder weather, having a tent outside is somewhat difficult. This is also the time when the healthcare has used the telehealth very well. So connect to your patients well through the telehealth, and this is very good for follow-up visits. So one thing I just want to stress again is that communication, education, and reinforcement in the infection control practices is very important. Because come to think of, we have been talking about this and knowing about this for almost a year, and now the fatigue starts to settle in. And we want to make sure that our patients as well as colleagues are all in line with knowing about the infection control practices and continuing to follow on that. And of course, we want to make sure we have adequate supplies. Few words about the COVID-19 infection in childcare centers. For childcare centers, we must implement social distancing strategies, and that could be done by staggering their time to come, staggering the time to sleep, and also the playtime. So there are groups of children in different time schedule. Also intensify cleaning and disinfection efforts in the center. Modify the drop off and pickup procedures. And that's kind of interesting. Some of the centers are using one parent as a volunteer to bring all children in and taking all children out, so they are not getting exposed to a lot of different people in the daycare center. Also, a lot of daycare centers are allowing infants to come in their car seat itself. So that kind of helps them, the environment remains more sort of controlled. Implement screening procedure upon arrival, so you can do the temperature check and also ask questions about the symptoms, etc. And of course, hand washing and gloving is very important. One thing I want to reiterate again, that if you are using glove, make sure that you change your glove between each person or each patient, or just use the hand hygiene. So the gloves could actually give you false sense of security. Maintain an adequate ratio of the staff to children to ensure the safety, and that's always important, COVID or no COVID. Just to give you some sense of security, this is the most recent study just published in January in the Journal of Pediatrics that studied the transmission rate from children to the daycare providers. And according to this study, the conclusion is that the exposure to childcare during early months of the US COVID-19 pandemic was not associated with elevated odds for infection in childcare workers. So if this gives you any sense of security, it did not increase the risk from children to daycare workers. A few words about the vaccine and healthcare providers. So what do we do if we are vaccinated? Well, the infection prevention and control recommendations for healthcare workers remain unchanged. You still have to use the same kind of PPE and hand washing and face covering, regardless of vaccine status. And that's what is important for all of us. Even in the private setting or in your the family setting, the mask should still be used. You're not just protecting your patients, you're also protecting your coworkers and family members. Few words about the school sports and COVID-19 infection. After the COVID-19 infection, most pediatric patients can easily be cleared for participation without extensive cardiac testing, but ensure that the patients have fully recovered and have no evidence of myocardial injury. Just to elaborate on that, should all children be tested for COVID before attending the sports? Generally, the testing is not recommended unless the patient or this athlete is symptomatic or has history of exposure to someone with the SARS-CoV-2 infection. And that testing should be done if needed with the PCR-based testing. We are not recommending antibody testing for this purpose. This is for the people who are in education department. If you are starting to open the sports, the things to consider are: what is the community level of COVID-19 in your area? What is the type of sports that the kids are going to play, to understand the physical closeness, such as football versus tennis or football versus golf. Level of intensity of activities, certainly football and basketball are more intense activities. Length of the time that the players are close to each other or to the staff, not just during play, but also on the bleachers. Setting of the sporting event or activity, indoor versus outdoor. Amount of the necessary touching of the shared equipment, such as bats and balls or even water bottles. And of course, age of the player. And I think in some ways that's easier if child is younger than 12 years, the risk is low as opposed to older children because most of the organized sports are done for 12 years and older. Players at the higher risk for developing severe illness, we must be aware of who are the players in our teams. Size of the team, the larger teams are certainly are much more closer together. Non-essential visitor and spectators as well as volunteers must be discouraged. And if essential, then of course they must use all the hand hygiene as well as the face covering. Traveling outside the local community is also important that if we are going in and taking the teams in different communities, knowing the community level of COVID-19 in that area is also important to consider. And of course, behavior of all the athletes as well as coaches on and off the field is very important. And the teaching about the social distancing, mask wearing, and hand washing must always be encouraged. So, what to do if the patient or participant has COVID 19 or has it during the season? So, any child who has SARS-CoV-2 infection positive is asymptomatic or mildly symptomatic, meaning the fever was for less than 4 days. It was short duration of muscle ache, chills, or lethargy. Those children should not go for any exercise until cleared by the physician. And the primary care physician then can use the pre-participation screening to check for chest pain, shortness of breath, that is out of proportion for URI, and new onset of palpitation or syncope. If all negative, then gradual return to play after 10 days of positive test and a minimum of 24 hours symptom free of the reducing medication can be done. I will go over the gradual return to play in few minutes. If any or new concerning history or physical exam findings are there, then these patients should get the EKG, consult with the cardiology, and further evaluation must be done based on the EKG findings. If the participant has moderate illness, required hospitalization, fever for more than 4 days, myalgia, chills, lethargy, but no ICU admission and no evidence of MISC, again, they should have minimum of 10 days since the positive result and positive symptoms. Positive for SARS-CoV-2 should not exercise until cleared by the physician, same as the mild patient. Again, they should have EKG and cardiology consult based on the symptoms and also to look for what the symptom resolution is and how long it is going to take. Cardiologists may consider ordering a troponin test as well as echocardiogram at the time of acute infection and then follow up as a later 2 to 4 weeks visit. Depending on the patient's symptoms and the duration, they may also require Holter monitor, exercise testing, cardiac MRI, and also if the cardiac workup is negative, then gradual return to physical activity can be allowed after 10 days. For severe COVID symptoms or MISC, a multi-system inflammatory syndrome in children, they should not participate in any physical activity or exercise for 3 to 6 months until the cardiology clearance has been given. The test for troponin test, echocardiogram, and cardiac MRI is needed for those patients. So for severe patients, the cardiology consult is really essential. So what is the graduated return to play? For the stage 1, for day 1 and 2, 15 minutes of light activity. Heart rate must not go more than 70% of the maximum heart rate. No resistance training. Day 3, 30 minutes or less. Add simple movements such as running drills. Again, no greater than 80% of maximum heart rate. Day 4, 45 minutes, no more than 80% of maximum heart rate, but now you can add resistance training. Day 5 and 6, 60 minutes activity and no greater than 80% of maximum heart rate. And by day 7, they can return to the full activity and participation. If there is any weakness or any symptom in between, then go back to day 1 and restart again. Just to go over the quick algorithm about the COVID-19 infected patient and their cardiac clearance. Pediatric patients with COVID-19 history infection, asymptomatic for now 14 days. Patient had mild symptoms, no, they can be cleared. Moderate symptoms, prolonged fever, although no hospitalization, no abnormal cardiac testing. Patient younger than 12, again, can be cleared. Patients who are older than 12, they should have EKG because prior to participation. If EKG is normal, cleared for participation. If EKG is abnormal, then they should go see the cardiologist and have the further testing done, and because there is a concern for myocarditis. And same thing applies for the severe symptom patient with the MISC, etc. They should have a myocarditis guideline to be followed with the testing with the EKG, echocardiogram, 24-hour Holter monitor, exercise stress test, cardiac MRI, and no activity for 3 to 6 months. So let's go to the COVID transmission scenarios, because that's something that we probably all will see in our patient care areas, especially in outpatient setting. As a healthcare provider, you are examining a young infant who is accompanied by his mother. Do your infection control precautions change based on the mother's COVID-19 status? If the mother is asymptomatic, pre-symptomatic, or symptomatic? So in cases of asymptomatic and pre-symptomatic is pretty much same because you do not know about their current symptoms. She may or may not even know about the history of exposure. So your best approach is to keep the mask on and have a good hand hygiene before and after. If the mom is symptomatic, regardless of the known COVID status, in that case, of course, you want to have a full PPE, which means mask, face shield, gowns, and gloves, and hand hygiene before and after. What if there are other factors? Because environment is always important in the transmission of infection. What if the exam room is small? And that's a very difficult situation to handle because you cannot just suddenly increase the size of your room. So one thing you can do is change the setup in the room so that there's more room to move around. You can put the examination table more towards the wall, maybe remove unnecessary furniture from the room, so make it a little bit more roomy so you're not close to each other. That's number one. Number two, do not allow too many people from the same family to come in the room. So if both parents are coming, maybe have only one parent and one child. If there are multiple siblings in the room, the one parent can wait in the car with other children. But this is for the best situation. However, if the mother is single parent or the father is there as a single parent, then it becomes a little bit difficult with multiple siblings. And in those situations, I think there are a lot of crafty things you may have to do. Either these children, all because they are together, they can be in the same room or wait in the waiting area with the mask on. And or if the older children are there, then they can wait in the car. Another question comes in sometimes when the hand washing is not performed appropriately. Now here I'm not trying to blame someone or finger point that hand washing is not done. A lot of times the rooms are not equipped with the soap and water or running water or wash basin. In those areas, I think the alcohol-based hand wash is really important and handy, so you can do your hand hygiene on a regular basis, and must be done both before and after examining the patients. Mask is not worn or incorrectly worn. This is an opportunity for education, and I would do that for all children who are coming in your offices, all adults who are coming in your offices, as well as all co-workers and front desk staff, because if you're not using the mask correctly and not covering your nose, you are not helping anybody. So therefore, use this as an opportunity to teach everyone and show them how the mask must be worn. Another clinical situation to discuss, COVID-19 infection in sports, because this is becoming a hot question right now as the schools are opening and the sports activities are starting. A 15-year-old varsity baseball player, positive for COVID-19, had fever for 5 days, chest pain, cough for 2 weeks, now has recovered and wants to play. Now, this is a child who is 15-year-old, and if I go back to the algorithm, he's more than 12 years old. So first thing he needs to have is at least an EKG. And based on the EKG, the next step must be done. And since the 2 weeks have passed and he is symptom free, he certainly is allowed to be out of isolation. And also, based on the normal EKG results, he can participate. If there is anything in the EKG, then of course, cardiology consult is a must. 16-year-old child with a positive COVID-19 2 months ago, not required hospitalization, but he was seen in the ED. In that patient, I think we really need to make sure that we have all the information, what was done in the emergency department, if there were any abnormal labs or so on. But since the 2 months have passed, that we can actually do the EKG and do the cardiac consult based on the EKG results. In summary, the protection and the prevention is the key. For all patients and all healthcare providers, face mask, hand hygiene, and safe distance must continue. My two things I tell everybody is 3 C's to avoid and 3 W's to embrace. The things to avoid is crowded places, close contact, and poorly ventilated closed spaces. 3 W's to embrace: wash hands, wear mask, and watch your distance. PPE is to protect you, your patients, and your families. Transmission-based practices are recommended for COVID-19 infection prevention. Telehealth is a safer way to stay connected with your patients. And COVID-19 and sports clearance is something that we have to continue to address as the children are starting to go to school and starting to play sports. And all the more important, get vaccinated for yourself, your family, and your patients. And of course, remember to wash your hands. You need 20 seconds to wash your hands. Thank you.
Thank you, Dr. Verma, for your presentation today. Once again, if you have any questions, please type them into the question box located at the top or bottom of your screen. Also, if you have additional questions after the webinar, please email us at njchapter@naap.org, and we will share those questions with our presenter and get back to you with their response. At this time, we have a few moments for some questions. So Dr. Verma, the first question, can you please give us instructions for patients traveling to and coming back from out of state? And also, if a healthcare worker is going out of state, should they get a COVID test after they come back or quarantine for the 10 days before coming back to work?
So it depends on your employment, actually. In most of the cases, if you are traveling outside state, you have to get the clearance from your employer, and that based on that, you will be required to either quarantine. And when I say quarantine, quarantine is generally for 14 days. Isolation is for 10 days. And also it depends on different states where you have gone and coming back, because every state has listed certain states that are not or that are in the list that if you're coming from that particular state, based on the high number of COVID-19 activity, you may require to do the testing.
We have students that will be returning to school hopefully soon. We have a student with a tracheotomy. What is the best way for her to come into school safely? Should she be wearing a mask and a cloth covering over the trach?
I think that's a very interesting question. And of course, considering the safety of the child in both ways, not only for the infection prevention, but also for her breathing status, it would be somewhat challenging. If the mask can be placed on the trach safely and the patient does not have any kind of respiratory distress, then I think that would be probably the best way to do.
Okay. How do you sanitize the N95 mask for reuse? And how long can you reuse an N95 mask in an outpatient setting like a vaccine center?
So in general, the cleaning is done. Only certain N95 masks are allowed to be cleaned and reused. So if there is a visible soiling, then it's better to not reuse it and just use a new one. If this is something that is used just for in a vaccination center, you can use the cleaning solution or the alcohol and just rub it on the surface and let it dry in a paper bag, and that's how it can be reused. Some of the hospitals are using ultraviolet light for cleaning those and reusing them. So there are different ways you can do it, but certainly cleaning solution or alcohol could be used for just the simple cleaning and drying it. But if it's visibly dirty or it's looking like frayed, or there are some, pieces are sort of coming out, or you see the threads, then it's better to just take a new one.
Thank you. There are districts that are beginning to allow greater numbers of students into the building. This would mean that some classrooms would go from having 10 kids in the room, distance between desks can be maintained well greater than 6 feet, to 16 to 20 students. Plexiglass barriers will be used at each child's desk and masks, of course. Do you feel that the benefits of children returning to school is worth the risk, since the distance cannot be ensured, but the other mitigation efforts can be in place?
It's a very interesting question, and I think it's something that is in everybody's mind, and it's an important one because I think we want the kids to be in school because the education in person is always better than the virtual education. We have seen that over the year. Based on whatever studies that have been done in recent months to year, the risk of infection from children to the adults in school setting has not panned out to be a serious problem. Having said that as long as we are maintaining a safe distance and using a good hand washing and keeping the mask on, then it's really beneficial that the kids go back to the classroom. So as I said, the two key things for those children would be keeping the mask on and using the hand washing. It's very interesting that, if you look at the hand washing data, before COVID-19, 1 in 5 people did not ever wash their home after using the bathrooms. And many people who even use the water to wash, they didn't use the soap. And in the similar population now, there is a 78% of population is using hand washing at least 6 times a day now. And 20% people are washing more than 16 times a day. So do we really need to wash 16 times a day? If really we are exposing our hands to different surfaces, why not? And that's why alcohol-based gels are really important because they can actually save your hands from getting dry.
Thank you. Should nebulizer treatments in school be eliminated and exchanged for MDIs?
That's another good question. I think in terms of the efficacy of the nebulized treatment versus the MDI, if you look at it, the MDIs are very, very efficacious in delivering the medication to the lungs. So I think as far as I'm concerned, yes, they can be switched.
Perfect. As you can imagine, we are getting a lot of questions. So light of everybody's time, I'm going to give you 2 more and then email you the rest of the questions and we can get back to the attendees if that's okay with you, Dr. Verma.
Mm-hmm.
Okay, perfect. What are your thoughts about small social gatherings with fully vaccinated individuals? Should they continue to wear face masks while indoors with others?
As of now, it's okay to have a small social gathering if everyone is vaccinated. However, the mask is still essential.
Perfect. And the last question, what should the frequency of cleaning, disinfection for unventilated bathrooms be?
That's a very difficult one to answer because depends on how many people use that room or bathroom. So it's going to be very tricky. Now, let's say we clean twice a day or maybe 3 times a day, does that eliminate the hand washing? Probably not. So I think no matter how many times that is cleaned, your need to wash your hands, it still remains the primary way that you can prevent yourself from infection.
How about one more? I have one more. That's a good one.
Yeah.
What about the use of water fountain? Do you recommend children social distancing while online going to classroom or during a fire drill?
So the water fountains are something that I personally never like because I don't think they, number one, are good for good hydration because you really cannot get a big gulp of water from that. So that's one problem. Second problem is I think even though it's touchless in some way because the water is going straight from the tap to your mouth, but you are touching that press button at the bottom of the fountain. So if somebody is conscious about cleaning that area, then I think they are okay. And what was the second piece? The lines in the
Right. As far as social distancing for lines going into the classroom or fire drills.
Yeah, social distancing is something that we have to continue to monitor for now, at least for in year 2021. That whether they are going from classroom to the other classroom in the halls, walking there, they have to continue to watch that.
Well, Dr. Verma and all attendees, on behalf of the New Jersey chapter of the American Academy of Pediatrics, I would like to thank everyone for joining our webinar today. As mentioned previously, CNE, CME, and MOC Part 2 credits will be awarded for your participation in today's webinar. A webinar link with the surveys will be emailed to you. Once your quiz is submitted, your credits will be issued and you can expect your certificate emailed to you within the next 30 days. As a reminder, this webinar has been recorded and will be made available on the NJAAP website. We hope that you will join us again on March 17th at 12 p.m. for our second Project Firstline webinar, Part 2, Evidence-Based Infection Control for COVID-19 in an Outpatient Setting, and this will include some case studies. Thank you. Have a great afternoon. This concludes our presentation for today. Thank you.
And I just want to reiterate, if there are any specific questions, I'll be very happy to answer. And I can actually give you my email address and people can directly email me. I'll be very happy to take all the questions.
Okay.
My email is my full name, Renuka, RENUKA .VERMA @rwjbh.org.
I can include that in our follow-up email as well.
Good.
Dr. Verma.
Okay. Thank you.
Thank you so much, everyone. Have a great day. Take
Yes.
care. Bye-bye.